we're doing the second part of this surgery, which is a semimembranosus flap to repair or to revise the previous perineal hernia surgery that I did a couple of weeks ago in this dog. Just bring this down like this and then attach it there. And so this dog had pretty severe bilateral perineal hernias, and then we repaired them with an internal obturative flap or bilateral internal obturative flaps. And then he had progression of his ventral hernia and had impaction of feces in the ventral rectal sac that he created right down here. So this is the incision from the previous hernia surgery that I did. And so now we're back, and if you missed the other part of it, we just did a cystopexy as well and a colopexy to try to prevent retroflexion of the bladder and to put some forward tension. What happened to our hemostat? Pull some forward tension on the rectum to try to prevent herniation. So if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So the herniation is right about here. And so my incision is going to go past the ischiatic tuberosity, which is right there, and then down the back of the leg. It's a new blade. I can start, but we're probably going to need a new one. All right, so I'm going to come from right here and then come past the ischiatic tuberosity and then down the back. I don't need it, that's all right. Yeah, all good. So the previous hernia repair was done about 2 weeks ago by me. And unfortunately, we developed or had progression of the ventral herniation. So that's saphenous vein right there. So we're right on the back of the stifle here. Get the Yankar on. Is suction turned on? Yeah. Thank you. Just put some tension there on the skin for me.
Oh, yeah.
Right.
Thank you.
Okay, so that's the semimembranosus right there. Semitendinosus is next to it. So that's semimembranosus right there. I'll just get a Gelpi retractor in here to try to give me little bit of tissue retraction. Cautery, please. Have a little bleeder here. Just go up for me there. And there. Can I get cautery turned down to 30 and 30, please? Or on the surface coag on the bottom there where it says 40, turn that down to 30, please. Thank you. Okay, so ischiatic tuberosity is there, and our semimembranosus is right here. And the twitching that we're seeing is not that Digger can feel this, it's just direct muscle stimulation. Not sure why that is. Yeah. Is that better? Weird. All right, so I can feel that we are into the hernia area here. All right, so I can feel the ischiacavernosus muscle right here, which is basically the penis, and that's stool, I believe, in the colon. So I can feel the other levator ani coccygeus complex over there, which is intact, and that's also probably my internal obturator flap, which is again intact and looks really firm on the other side. I just want to get into that levator ani because that's as far as I need to go for my repair.
Is this the end of one?
Let's see. Could be. And then this here, that could be prostate. So you have to be careful that, like I have heard of people inadvertently removing the prostate thinking that it was a retained testicle during a hernia repair. And that's a very upsetting outcome. So that's the ischium right there. That could be sacculation of the colon.
This is quite solid.
Yeah. And that little fat globule right there looks very much like contents of a perineal hernia. Okay, so that's levator ani up there. So there's a question if I previously did a cystopexy and a colopexy. I did just a few minutes ago. The Gelpi in here. So that does feel very hard. So that's the levator ani there. Anus is there. That must be prostate. And I need to expose things enough that I know what I'm suturing to. So I can't feel the urethra. Okay, so that's in the pelvic canal, and that's definitely colon all the way up to there. So that's hernia there, that's colon there, levator ani up there. Still haven't quite worked out what that is. That's coming off the ischiatic tuberosity there. Ischiatic tuberosity is there. That is part of the hernia. What is that coming off of? And I'd like to try to find the anal sphincter as well.
One of the reactive lymph node, or
I suppose so. It'd be a weird place, and it feels too rubbery to be lymph node. There, please, for me. And then just up there. Yep. All right, so what can I suture to down here? It looks.
it doesn't look like, it looks quite irregular.
It sure does. It almost looks like what a. You know what it could be is a stump from the castration.
Oh, is that big? Oh.
Okay. All right, so I'll bring this around over here. Let's see, what am I going to suture to here? Just get big bites down there.
Are you suture to the coccygeal?
Yeah. So just dissecting down onto the ischium. All right, so this is the flap of the semimembranosus that we're going to take.
Do you need to inject some lubricant before you transect, or?
Nah. And again, this twitching that we're getting is not that the dog can feel it, it's just that I'm directly stimulating the muscle with the electric cautery. And I'm just assessing, so I've got a blood vessel coming in here that I need to preserve. That's the adductor muscle right there.
So the one you need to preserve is a caudal-gluteal?
No, there are two vessels that supply the semimembranosus, which are branches of the femoral. Okay, and so that's attached there to the... All right, so... the lump ventral to the tail base was actually the way I closed it when I closed the hernia. I had some extra skin. The thought that it's a perianal adenoma is actually a really good idea. I don't think that's what it is, but that's not an unreasonable guess. All right, so I will take that full thickness. Okay, and simply just bring that up there. Just like that. All right, so I'll get you to hold on to that, please, and provide some retraction.
Just by retraction?
Yeah. Hard?
Hard?
Yeah. Now, can I get some OPDS, please? Or 2 OPDS on a taper needle? Getting some nice thick bites into the internal obturator and levator ani. I'm going to do kind of a locking loop pattern. Can you hold on to that tip, please? That. And again, that. Question about whether it's worth biopsying that. I'm just worried that it's part of the urethra, and so I'm worried about getting a urinary, like a leak, into my incision. It's actually not a bad idea to biopsy it, but I don't think I will. So you can see I'm doing kind of a little locking loop pattern on that muscle.
Is it kind of similar pattern how you repair the Achilles tendon, or does it different one?
Yeah, exactly. So Cindy is asking if this is the same way that I repair an Achilles tendon, and that's exactly right. The flap is quite fat. It's possible that I could have done it partial thickness, but I was just worried about the blood supply. Sorry.
Do you need OPDS, or it's fine?
I think it's okay. Thank you. Just hold on to that tip there. Grab that with a hemostat if you want, if we have one. Yeah. Okay, so now we're going to have to really get some retraction in here so that I make sure I'm getting adequate bites in the anal sphincter. Get a Sen retractor, please. Yeah, thank you. You know, can I get a 22 gauge needle and a syringe, and I'm just going to do at least an aspirate on that. This procedure can, so Josh, so what we've got now is just a ventral hernia. And so it used to be lateral on both sides, now it's just gone ventral. And so the lateral hernias have not failed. You can use the same flap to...
The syringe is ready.
You can use the same flap to repair failed lateral hernias as well, but that's not what's happened here. Oh, it's just a seroma. From either the castration or, so the mass has disappeared now. Let me just squirt it out here.
You don't need to check it?
Now.
The seroma can be so solid.
Yeah, so that's great. So it's completely gone now. All right.
Now this one?
That's ischiatic tuberosity, and then the internal obturator. So just hold on to that, please, for me. Now let's see where my sphincter is. See, that just feels like connective tissue there. That feels solid. So I have not had abscesses form after this surgery. I have had infections, but not abscesses. Can you lift up on that? Post-op care, we're going to keep it on high fiber diet. Probably no lactulose unless it's really struggling to defecate. And then pain relief in the form of methadone, meloxicam, paracetamol.
Does it have to be like low residual diet or?
No, no, I like them to have lots of fiber so it bulks up the stools. Okay. And I'll just keep this dog hospitalized, probably overnight. I like sending patients home as soon as possible because I think that they recover better at home than they do in hospital. Once we get past the immediate post-op pain period, like if I feel like we can get adequate pain relief at home, I don't think there's any reason to keep them hospitalized any longer. Can I get some more 2O PDS, please?
So this one we don't need to use the proline just because we want it to...
This will heal, yep. I mean, we've got cut muscle. It's actually not, that's an interesting consideration. I think that this is going to form so much scar tissue very quickly.
So we don't need to use proline.
So I don't think we need to use proline. Now I need to figure out what I'm going to suture to ventrally. Hold on to that, please. I think it doesn't go under the flap. Pick up some periosteum. Can I please get some I've got some O-proline here. Let me see if I can grab.
OPDS or?
O-PDS, sorry. that feels pretty good. Let's just get some saline lavage, please. And is suction turned on? Yep. Go ahead. Go ahead. Can I get some more OPDS, please? I'm just going to suture that cut end of the semimembranosus to the adductor muscle.
Is that so we can avoid further atrophy, or?
Yeah, just so that it has something to pull against, and try to avoid maybe a little bit of the lameness that you can sometimes see with this.
Yeah.
You should be able to turn off the suction now. Yeah, that's great, thank you. Yep. Yeah, thank you. All right, so now we'll just do a sub-Q layer closure. So he'll be sore after surgery, but we will really be on top of pain relief. I think we'll probably put on a fentanyl patch and then methadone in hospital until the patch kicks in 12 to 18 hours. Get some idea of where this skin is supposed to go. don't have any more towel clamps, do we? I think I've used them all. Ah, that's right. Okay. So there's a question from Claire, who owns Digger, as to whether we would consider physiotherapy, and I think that's actually probably a great idea. We've got Australia's best physiotherapist just around the corner from us, and so if that's something, Claire, you're willing to do, I think that that would be a really good idea. Can I get some more OPDS, please? And so after the stitches are out or after everything's healed, swimming I think is probably a great idea. And then gradual return to normal activity. Trying to make his bum look nice.
Do you just do simple continuous for your purse string?
Just because his skin was just kind of laying there in a linear fashion, and so.
So it looks horizontal.
Yeah. And I will pull that out before we take them off the table and just make sure I'm happy with how everything feels.
Yeah, sure.
Is that a suture from the previous surgery? Yeah, you can cut
Yes.
that and that one. Look at that snug little bottom. Looks good.
Looks symmetrical.
Take the 2O for this part. Pull that dorsal, yeah.
Got a question about, do you have any concerns about seroma formation?
So that's a good question. I don't have any concerns because we didn't have really any oozing at the end of the surgery, and it's a very muscular and vascular area. And so the answer is no, I'm not particularly concerned about that. Can you get some more 2O on a taper, please? 2O PDS. Thank you.
Do you need table higher?
Hey?
Do you need table higher or?
Yeah, can I have the table up a little bit? That's great, thank you. Can we give a dose of cefazolin, please? Okay, great. And he's had his second dose?
Yeah.
Great. Thank you. I guess the other thing we could think about doing on him would be an epidural. I think that'd probably be a good idea when we come out. Yeah.
You want to do it before we wake it up? Or?
Yeah. That'll make him heaps more comfortable.
Yeah.
And he won't have a primipore or anything on here.
No need for any dressing.
Hey?
Do you need any dressing? No.
No. All right, I'm going to switch sides with you.
Yep.
So the patient is in sternal recumbency. Hold on to that, please. And we're looking at the backs of his knees, and I'm suturing right ventral to the anus. Thank you, Claire. I want to make sure that I do something that's going to be nice and snug and also not have any skin sutures that need to come out because of diggers. I think that it would be really uncomfortable for us to try to remove sutures. So we always adapt what we're doing for the patient. And Claire, having worked with human doctors, I didn't want you to be too disappointed with the job that your vet surgeon could do. I also want to make a watertight seal because this is a contaminated area.
So that's why you have a bite of the skin.
Yeah. So almost like a little bit of inversion. that tissue around the previous surgery is a little bit friable. It's not unexpected. So I'm going to have one stitch that needs to come out here.
Is it too friable so you can
Yeah, and I'm just not going to be able to bury the
yeah.
knot very well. All right, so now the moment of truth. We're going to cut the purse string out. So Tiana, I'm cutting the purse string out.
Yep.
Get some scissors, please. And a sore little bum from the purse string. Yeah, that feels so much better. Yeah. Okay. So that's pretty much it from me. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on the phone next time we live stream. And we will